Thank you very much. It's lovely to be with you today, and I'm going to start with an apology for a persistent cough that I'm sure, like millions of people, you'll understand the cause of that. So apologies if I cough and splutter my way through the presentation. On behalf of myself and Leona, thank you for inviting us to speak. This presentation and the toolkit that we're going to talk about is based on learning as a result of the pandemic. Opportunities for learning and improvements are always a positive outcome of infection prevention and control incidents or outbreaks. You all will have experienced this. And the pandemic is no different. Our learning on the transmission of COVID-19 has been extensive and challenging. It will require us to embrace a changing culture and strengthen relationships with our health and safety colleagues, and Leona and I work very closely together on a day-to-day basis to ensure that they can deliver their role, and together we can protect not just our patients, but our healthcare workers from biological or infection risks. Now, I'm going to start with another apology, and that is that myself and Leona have to leave after the presentation. So we won't be around to answer questions, but you can, if you have any queries, either contact me or Leona directly or go through Paul Anthony, who will pass the queries on to you. So, the COVID-19 pandemic has, we believe, been instrumental in focusing our attention on respiratory pathogens and the risks they pose to healthcare workers and patients in a way that we have never been forced to do. Pre-pandemic, really our focus was on specific infections, such as open pulmonary tuberculosis, perhaps measles, and for those of you that have more experience in high consequence infectious diseases, potentially MERS, SARS, or other infections. Where infections common to the UK in everyday life has been managed, we haven't really thought about respiratory risks unless associated with aerosol generating procedures. So this hasn't really affected our thinking in relation to our day-to-day interactions with patients, and for us in the Royal College, how we deliver care as nurses in patients' own homes, hospices, care homes, and hospitals. This is not just a hospital issue. So the pandemic has forced us to reevaluate our approach to managing the health and safety of staff in this context like never before. So a couple of key learning points. Healthcare workers are at much greater risk than the general public, and this is a really important point in terms of their risks of contracting COVID-19. The risks increase for healthcare workers because of the physical contact and the close proximity they have with patients, and it is that risk that increases their chances of acquiring an infection in the workplace. This is about acquiring infection at work. In terms of robust control measures, there are many lessons to learn that will help protect not just the current workforce, but our future workforce. And we need to reflect and reconsider how we manage many respiratory infections, not just those that are hitting the headlines currently. And lastly, the culture in health and care towards health and safety. Cultural change is now required to strengthen the importance of risk assessment across the board, but particularly for the protection of healthcare workers across a range of hazards and situations, and policies and guidelines must align in order for us to achieve this. Infection prevention and control guidance, whether national, international, or local, is essential in supporting both employers, your bosses, and employees, that's you, in the health and care sector to practice safely. Where a biological agent or pathogen, a virus, for example, can cause serious harm to health, due to the nature of the work being carried out, specific health and safety legislation must be adhered to. Many of you will be aware that this already applies in laboratory situations, but this also applies in patient interactions. Regulation of health and safety law in the UK is carried out by the Health and Safety Executive and the Health and Safety Executive Northern Ireland. So two different organisations, but they work together in terms of the overarching legislation. Published infection prevention and control or other guidance should support employers to comply with their statutory duties. Therefore, infection prevention and control guidance must align with health and safety law. Leona, do a dance.
Do a dance. Thanks. Okay, so UK health and safety law sits under the Health and Safety at Work Act 1974, and in Northern Ireland, the Health and Safety at Work Order, Northern Ireland 1978. The overriding duty for employers is to ensure the health, safety and welfare of their employees whilst they are at work, and also non-employees who may be affected by the work being carried out, so far as is reasonably practicable. For example, the safety of a nurse caring for a COVID-positive patient and preventing patients who are negative from contracting the virus. Regulations sit under the Act or Order, with the majority of regulations in Northern Ireland aligning with Great British regulations. Non-compliance or a breach of health and safety law is actually a criminal offence. When you work directly with a biological agent that can cause harm to health, then the Control of Substances Hazardous to Health regulations, or COSH, applies. SARS-CoV-2 has been classified by the Advisory Committee on Dangerous Pathogens as a Group 3 biological hazard, meaning it can cause serious harm to health. In health and social care settings, the nursing workforce are working directly with SARS-CoV-2, COVID-19, for example, providing intimate care for COVID-19 positive patients. So therefore, with regard to working directly with positive patients, the COSH regulations apply. And the application of COSH in relation to COVID-19, does not apply to occupational sectors where the employees are not working directly with the virus. So, for example, on a building site, in a factory or a garage, then the COSH regulations wouldn't apply in this situation. But for healthcare workers who are working directly with the virus, i.e. intimate care for COVID-positive patients, it does apply. And it means that health and care social employers have a duty to carry out a suitable and sufficient risk assessment in accordance with Regulation 6 of COSH, taking into consideration the hazardous properties of COVID-19, including how it is transmitted. For example, it is transmitted via the airborne route, the level, type and duration of exposure, the approved classification, i.e. a Group 3 biological agent, and how the work is being carried out. For example, is it in a patient's home? Is it in a high dependency unit? Is it in a hospice, a prison, a mental health facility, or a care home? The risk assessment should be carried out by a person competent to do so, in consultation with employees and/or their representatives. Where it is not possible to prevent exposure, then adequate control measures are required. Personal protective equipment and respiratory protective equipment are at the bottom of the hierarchy of controls, as they fail to danger. However, where a significant risk remains after other control measures, such as ventilation and distancing, have been implemented, then suitable PPE, RPE should be provided and be readily available. And where a tight-fitting FFP3 mask is provided, then face-fit testing for the mask being used must take place. And it's important that staff are provided with relevant information, instruction and training that's easy for them to understand. So to summarise, the key steps for carrying out a suitable and sufficient risk assessment in accordance with the COSH regulations are as follows. The person carrying out the risk assessment must be competent to do so with the relevant skills, knowledge and experience, and should carry out the assessment in consultation with workers and/or their representatives. The hazard should be clearly identified. For example, SARS-CoV-2 is a Group 3 biological hazard transmitted via the airborne route. The level and type of harm should be identified and who is at risk, including the route by which it enters the body, the effects of exposure from each route, how often people are exposed and for how long, and also who else other than workers may be harmed. For example, the risk of serious respiratory illness from breathing in COVID-19 particles. Evaluate how to prevent exposure. Think about what is already being done. For example, maintaining distance and, where practical, patients wearing face coverings. Identify if improvements are needed to reduce the risk of exposure so far as is reasonably practicable. For instance, nursing staff wearing an FFP3 mask when providing intimate care for COVID-positive patients. And implement, record and keep under review. Using the COSH regulations for respiratory hazards at scale is a relatively new concept. A lot of employers may think of COSH as relating to things such as cleaning chemicals or contaminated waste. In health and care settings, COSH regulations are used to control exposure to bacterial infections such as open pulmonary TB and for viruses originating from blood and bodily fluids. But the concept for common respiratory viruses is new, but the law hasn't changed. The Health and Safety at Work Act has been law in Great Britain since 1974 and COSH regulations since 2002. The duties on employers to assess risk and for employees to comply with control measures haven't changed either. The RCN took steps to support the health and care workforce with the creation of a toolkit, which I'm going to pass over to Rose. Thank you.
Thank you. So just to remind everyone, because we are in a very different situation to the one we were in, in early 2020, COSH still applies despite the fact that we now have vaccination. So don't confuse the ability to vaccinate people with the need to not undertake risk assessments or think about the management of COVID-19 within health and care settings as not required. It still is. So why a toolkit? So many of you will be aware we've been doing quite a lot of work during 2021 on looking at the protection of healthcare workers. And in December 2021, we launched the toolkit in collaboration with a number of other organisations. These included the COVID Airborne Protection Alliance, called CAPA. They were previously known as the AGP Alliance, which have about 20 organisations as members, the British Occupational Hygiene Society, Royal College of Speech and Language Therapists, and others. So this is very much a wide, collaborative, multi-professional toolkit that has been developed. And other professionals, if we take the speech and language therapists, for example, also very concerned. Their members going into schools, their members doing swallowing assessments, close-up contact with patients at equal risk as nurses. So the need to undertake this was based on requirements to respond to our members' concerns. The aim being to provide support and guidance for employers, your bosses, you in your roles as infection prevention practitioners, and all other health and care employees. And for organisations such as the RCN, which also has a trade union function, even though I sit in the Royal College part, ourselves and the BMA, we have safety representatives who also needed advice and support to carry out COVID-19 risk assessments. Although hosted on the RCM website, the contribution was from many, and it remains a collaborative effort. So why a toolkit? Well, the toolkit covers, we hope, all information that you need to support the undertaking and understanding of risk assessment in the health and care workforce settings. And it covers all aspects, as we said, from employer to manager to employee. Now, it's really important that we start with and acknowledge the mode of transmission of COVID-19, because this is absolutely critical to enabling you to undertake a COSH risk assessment. If you don't have clear information around the transmission route, this has real implications for decisions that are then made down the line. And the COSH risk assessment has to be suitable and sufficient. The COSH approved Code of Practice L5 can provide more information on this if you want to look at it. Now, we know now that normal life activity, all of you sitting here today, will be producing different size respiratory particles. There is now, we understand, no definitive black and white line between a droplet and an aerosol, and therefore infection prevention and control guidance as a result of that. So we understand that patients in chairs in their own homes or in beds are producing different size aerosols, and therefore this is an important part of the risk assessment. The risk assessment does not, the toolkit, risk assessment toolkit does not represent alternative guidance. Rather, it sits between existing infection prevention and control guidance and health and safety law to guide employers and individuals through the process. So it's the glue that binds it together. So as mentioned, there's a lot of discussion around whether SARS-CoV-2 is airborne, and this is just one example. It's quite a nice visual example from Wilson 2020, which shows our emerging understanding on this issue. It's important to note that when considering risk, it's key to focus on the risk which causes the greatest harm, and this is important where there is uncertainty over the level of risk. So therefore, we have to start with considering the airborne route of transmission rather than the droplet route in order to prevent harm from occurring. Leona. There you go.
Okay. So you'll see on screen the homepage of the toolkit. It can be found on the RCN website via the COVID-19 information pages, or using the link, if you can just see it, there is a link at the bottom of the screen. There are different easy-to-access sections, which you'll see on the left-hand side, in introduction, advice for employers, etc. And it provides appropriate advice and guidance, whatever your role is. So, for example, if you're an employer, if you're a manager, healthcare worker, or a safety representative. The tool explains the process for anyone who is carrying out a COVID-19 risk assessment, and you simply enter the boxes at the bottom there for further information. So, for example, if you enter box 1, competency, that looks at whether you're competent to actually carry out the risk assessment. Box 2 looks at the steps that you need to take to carry out to identify risks. 3, how to identify adequate control measures. And 4, the use of those identified control measures. And box 5, information, instruction and training, which is key so that people understand what they need to do. The toolkit also provides a link to a guidance document which has been based on the Health and Safety Executive's HSG 53 on respiratory protection. So we've taken information from there and produced a guidance document, and that provides information about respiratory protective equipment. It's worth noting that fluid-resistant surgical masks are not classified as RPE. RPE is a form of personal protective equipment which protects the wearer from breathing in airborne substances hazardous to health, such as COVID-19, and a suitable and sufficient risk assessment should identify when it is required. Where RPE has been identified as a control measure and a tight-fitting FFP3 mask has been provided, then it's crucial that a face-fit test by a person competent to do so takes place. In addition, and this is really important, where tight-fitting masks have been identified as a control measure and they're being used, they should not be worn continuously for more than 1 hour at a time. So the situation in January, we just did a little snapshot just to see what was going on out there. And these are some of the comments we got back. So, trust refusing to allow staff to wear FFP3 masks when COVID facing, insisting surgical masks are used. Face-fit testing not taking place. COVID not being considered as part of a pregnancy risk assessment. So there's still confusion and misinformation out there, and that's our role really, is to allay that confusion and prevent nursing and healthcare staff being put at risk.
So I'm going to finish off now, and I heard the murmurs about the continuous wear time for respiratory protection being an hour. This wasn't outlined in the guidance on sessional use and infection prevention and control guidance, and is a requirement by the Health and Safety Executive. So that's why it's so important that your health and safety colleagues work with you in terms of determining local guidance to make sure it not just fits from an infection prevention and control perspective, but from a legal health and safety perspective. So living with COVID does not mean ignoring COVID, despite the policies that may be in place for the general public. In health and care settings, COVID-19 remains as a core patient safety issue, and we must remember that in order to protect our patients and also to protect our staff. Despite the fact that the severity overall of disease is less, we are facing huge numbers of infection, and it still remains a debilitating disease for many. Employers still have a legal duty to carry out suitable and sufficient risk assessments and ensure adequate controls are in place, and we have to match this with the demands of the elective backlog and emergency patients. So where the risk of infection is high, an FFP3 mask, in addition to other control measures, must continue to be worn. So the last slide, post-presentation action, something for you to take away and think about. So we would ask you to go back and reflect on your local infection prevention and control policies. Do they really meet health and safety legislation requirements, or is there just a cursory reference to health and safety law? Do they reference and link to current health and safety policies? Do staff have a knowledge, working knowledge of these policies? Go and find your local competent person in health and safety. That might be your health and safety lead if you have one. It could be somebody else. Go and meet with them. Talk about your policies. Talk about what's in place, what needs to change, potentially. Ask for, you have a right to, and read your organisation's risk assessment. Reflect on it. Is it fit for purpose for your local population, your local situation, your practice? And read and reflect on the RCN risk assessment toolkit and consider what else might need to be done in your place of work. So I hope you found that interesting. I hope you learned a thing or two. As I said before, we're very happy to take questions. Apologies, we have to go and do some other things today, so we're not able to stay. But thank you for having us.